This is a 44-year-old patient presenting with severe menorrhagia for 6 to 7 months. On transvaginal sonography, you can see on 3D that there are G3, G4 myomas and one submucous myoma, which is about 2 centimeter by 1.5 centimeter. The plan was to undergo a vaginoscopic approach to map the pathology and decide the removal of the myoma. And as you see in the vaginoscopic approach, which is a traumatic entry into the cavity using the Betoki 5 scope, you can see a myoma about 2.2 centimeters by 1.5 centimeters. We start the mapping of the myoma. We are unable to see the right ostia. The anterior wall is seen. We see the left ostia. You can see slightly thickened endometrium, and this is how we map the apex, the base, the spread over the endometrium is mapped, so we know how much of the base has to be removed. And then we introduce a resectoscope, which is 18 French resectoscope. So without dilating, under vaginoscopic technique, we see the left ostia, and now the plan is to resect this myoma from the apex to the base. We extend the loop so as to hide the loop, activate the current, and then release the thumb gradually towards us, thereby taking out chips sequentially from the apex to the base. As you come towards the end, we slightly elevate the scope so as to cut the chip, and we go in a very synchronous manner, and the current is activated only while we come towards the surgeon. Again, hiding the loop, the same steps are followed again and again, and this is how we try to reach the base of the myoma. While removing these chips, we deflect the chips to the opposite side so as to maintain proper vision and prevent obscuring of our vision. The glow that you see on the loop is nothing but the plasma. That is plasma kinetic energy that we are using, wherein when we give current to normal saline, the NaCl is dissociated into active sodium particles, and these active sodium particles are actually responsible for the cut, and therefore you see the glow, which is known as the vapor pocket. So we have to create a vapor pocket initially so as to cut, and this is the difference between a bipolar or plasma surgery and a monopolar current. You can see how the chips, as they accumulate, obscure the vision, so the surgeon should be alert in pushing the chips. You can see the glow, which is the plasma, and as you come down towards the base, you will see little bit of charring. Now this plasma kinetic energy works at very low voltage as even compared to the bipolar. Here you can see the pseudocapsule of the myoma. So here we take small ice cream scoops of the fibroid. You can see the whiteness of the pseudocapsule. Respecting the pseudocapsule is of vital importance so as to prevent any bleeding and damage. You can also see a small myometrial cyst. So this is a surprise which was not caught on sonography, wherein we could see adenomyosis at the base of the myoma. And now what we do is, in adenomyosis there is no capsule. So here the endometrium is intervening between the myometrium, and therefore there is no line of differentiation. So here we have to see for the pink tissue and just remove the brownish tissue on top. This is how we try to identify macroscopically, and we will remove this cyst wall completely. You can see how sticky this tissue is as compared to the myoma tissue. There won't be any capsule, there will be fibrotic bands. Here you can see there is no connective tissue as compared, and here you can see another lesion which is fibrotic in nature, and this is clearly when you see the endometrial glands entrapped within the myometrium, the response is of fibrosis first. So small ice cream scoops. now that we don't know exactly the demarcation in the adenomyotic region. Having done this, we remove the chips either by the loop or with the O molding forceps. We revisit the cavity again to see the fovea, to see for hemostasis, removing all the chips now with the loop of the 18 French resectoscope. This is sometimes tedious but has to be done properly. If these chips stick to the loop, just activate current, they get released. Whenever there are air bubbles, go within the air bubbles with the scope and activate suction. Now we are inspecting the fovea. You can see the cavity clear. You are able to see the right ostia, and now still a little bit of the adenomyotic tissue is remaining, and here you will appreciate how sticky it is. It will not cut immediately. You have to use proper current to activate it, and now the differentiation point will be seeing pink myometrium below the adenomyotic tissue. So this has to be done carefully to prevent any form of perforation, because the depth is now not known to us. There is no guiding element over here. In a myoma, you have the pseudocapsule which guides you, and here you see now we are resecting very superficially, and this may be the last few bits of the adenomyotic tissue which we remove. So this was a case wherein we had a submucous myoma G0, very easy to remove, but you had adenomyosis at the base of the myoma, and this also has to be removed so as to give symptomatic relief. When time taken was 20 minutes and the deficit was only 400, and you can see the histopath report showing adenomyosis with submucous myoma. So this is one has to do maintaining proper fluid balance and then looking after the safety of the patient also. Thank you so much.